is Sean Phillips, and I'm the Head of Health and Social Care here at Policy Exchange. It's my great privilege to welcome you and to be able to chair this next event in our Fringe programme. And the question that we're asking is, how will the government deliver its long-term workforce plan for the NHS? And I'm really delighted to say that we've partnered with the University of Surrey for this conversation. And this is a subject that we at Policy Exchange care very much about, and we were pleased to set out some of our own thoughts about how a significant expansion in the medical workforce could take place in a report that we published last year called Double Vision, and we have copies of that just outside, which you're more than welcome to pick up. And we were pleased to see that a number of the measures that and approaches indeed that we advocated in that report were reflected in this first of its kind workforce plan. In fact, it's actually really been it hasn't been since the early 2000s that we've seen a workforce plan which is quite as kind of in-depth and certainly long-term in its vision. And it includes some striking but sort of key visions, a proposal to double medical school places, and really opportunities to expand training in understaffed specialties, general practice being a core one, but also to think carefully about how we can place doctors effectively too as a core part of that, to expand opportunities for people who maybe traditionally wouldn't have joined the medical workforce and would miss out on a career in the NHS. It's indeed welcomed by many stakeholders when it was published, but also raises very many questions. And so we're here to ask, how indeed would a plan that's as bold as that be delivered, and what are some of the pitfalls that need to be considered, both political and indeed fiscal as well? And very recently, for instance, the IFS published a report that showed that up to 40% of the, more than that, almost 50% of the entire public sector workforce would be working in the NHS if this plan were to be delivered. So this is a very significant commitment that the government is making. So to consider these questions, I'm really pleased to say that we've assembled an excellent panel. To my right is James Morris. James was the Minister for Primary Care and Patient Safety last year, and he's currently a member of the Health and Social Care Select Committee and has been the Member of Parliament for Hales Owen and Rowley Regis since 2010. To my left is Professor Camilla Hawthorne, who's the Chair of the Royal College of General Practitioners. She's been a GP for 34 years, a majority of those spent working in South Wales. Very wide experience in general practice of running community projects, particularly in diabetes and heart disease, and has twice been named GP of the Year. She was also the head of graduate entry medicine at Swansea University, so brings real expertise in medical education. To the far side is Jacob Lant, who is the newly minted Chief Executive of National Voices, which is the leading coalition of health and social care charities in England, with more than 200 members. And last but not least is Professor Juliet Wright, who is the founding dean of the School of Medicine at the University of Surrey. She was formerly the director of undergraduate teaching and learning at Brighton and Sussex Medical School, and she has real expertise in the assessment of frailty in elderly HIV and oncology patients in particular. So a real range of expert perspectives to bring to this question. So in terms of the running of the session, I'll be handing over to each of our speakers in a moment. If it's okay, I'll perhaps start with James and wrap up with Professor Wright, where they'll deliver up to 5 minutes of opening reflections on this question. Then we'll discuss some of the key issues as a panel, and then it's over to you for the final 15 to 20 minutes. And our only house rule here is that you state your name and organisation once you have been given the mic. So really, without further ado, pleasure to hear what you have to say, James.
I will stand up. Well, thanks very much. I think to start with, it's worth just making the point that it's quite good that we've got a long-term workforce plan for the NHS. I think it's the first time in the NHS's history that there's been a long-term workforce plan. Now, many people might say it took a little bit of time for us to get there, but at least we have it. So we have a statement of a long-term workforce plan for the NHS, which I think we can all agree is a good thing. But the implementation of this workforce plan obviously has some significant challenges. And they're not just about numbers of people, and I don't think they're even about numbers of pounds either. Because one of the things which the long-term workforce plan talks about up front is the fact that in order for it to be delivered, we need to have a significant transformation in the way the NHS operates. It's quite explicit about that in terms of improving productivity within the NHS, including the application of digital transformation within the NHS, and also data and the way that we treat data within the National Health Service. All of these things are critical components of a transformation of the health service to make it operationally more efficient, innovative, and delivering improved patient care. And it seems to me that whatever discussions, and they're completely valid discussions that we will have today about the number of doctors required, the number of nurses required, how we implement multidisciplinary working within the NHS. All of those conversations are entirely valid conversations, but unless we're all committed and there is a commitment to this long-term transformation of the operation of the NHS, then the delivery of a long-term workforce plan will probably hit the buffers quite quickly. So, because recently, for example, we did an inquiry for the Health and Social Care Select Committee into digital transformation in the NHS, and I think it's fair to say that it's a variable picture. Sometimes we can't even send letters from hospitals to GPs. But on the other side of the equation, we are getting better at the application of some AI and so on in terms of improving medical practice and diagnosis. So it's a variable picture. The other part of the long-term workforce plan, which is in that whole bucket called retention. Now that again seems to me to be absolutely critical, and it talks about improving the culture, health and well-being for those who work in the NHS. And that seems to me to be of absolutely critical importance when we're considering the long-term workforce plan. How do we genuinely create a better culture within the NHS so that people want to stay? We have a workforce which is dedicated and committed to the delivery of high levels of patient care, but I think the reality is that there is much, much more needs to be done in order to improve that culture and improve the health and well-being of people working within the NHS so that we can stop, or at least go some way to stopping the level of attrition we have in terms of retention of critical staff within the NHS. And so that whole cultural question, I think, is absolutely central to what we're talking about. And the other point I'd make, which is, and it's part of the discussion about what sort of health service do we want in the future, which is that we need to move towards a situation where we're focusing much more on prevention. Again, with the Health and Social Care Committee, we're doing an inquiry into prevention. You can kind of see it from space, this inquiry, because it's huge if you think about prevention. But it is a critical piece of work because, as the chair was saying, if the IFS is saying that 50% of the entire public sector workforce will be working in the NHS if this plan gets implemented, the NHS will be taking up close to a third of all public expenditure by that time. We're spending 185 billion in the next financial year. So unless we move towards a preventative model rather than an illness model in the NHS, it's going to be unsustainable. And again, an idea of a long-term workforce plan in the context of us firefighting our way through, I don't think is going to be sustainable. And the final point I'd make is, again, about the integration of health and social care, which has been a subject of debate over a long period of time. Ultimately, we do need to move towards a situation where the health and social care workforce is seen as a continuum. But that speaks to a wider discussion about the long-term funding of social care. But it seems to me that that integration is again critical to the successful implementation of a long-term workforce plan. Social care is absent or almost absent from the workforce plan, and we do need to think about how that integration works, because we want to move again towards this prevention model. We want to move towards a different model of delivery where health and social care are more integrated. That is of central foundational importance. So those would be my reflections on our challenges, Chair, and thank you very much.
Well, many thanks, James. I think you've placed this conversation in sort of that really broad perspective, and look forward to getting into some of the topics that you picked on in some more detail in the conversation. So perhaps if I hand over to you next, Professor Hawthorne.
Thank you. Right. I will certainly address some of your points in a moment, James. But first of all, I think I don't need to tell the people in the room that general practice is in crisis. Appointments are 9% up since 2019. We're seeing millions more patients per year than we were a few years ago, but the number of GPs is going down. And although the number of trainees is going up, GPs are leaving the profession faster than they're entering it. So we are about 900 plus full-time equivalent GPs short of where we were 2 years ago. We saw 340 million patients in 2022 in England. 2/3 of GPs in a recent survey that our college has done say that they don't have enough time to care for patients safely. And certainly when I'm the on-call doctor in my practice, it's quite easy for there to be at least 70 people that I need to assess in one way or another, whether it's on the telephone, whether it's by e-consultation, whether it's face-to-face. It's a combination of all of those things. That's a lot of clinical decisions to have to make for one person in a day. And when that happens day after day after day, it's not surprising that people are getting burnt out. So that's affecting GP well-being, which is why retention and well-being and occupational health that's in this long-term workforce plan is welcomed, but it wasn't clear from the plan how that would apply to primary care, where it is extremely needed. It's also interesting that the NHS and Department of Health don't appear to be really looking at the patient journey from its beginning to its end. So, for example, there is no funding this winter for winter pressures in primary care. There is funding in secondary care, although you'd have to talk to Adrian Boyle about whether he thinks it's enough or not. And I think that's really short-sighted, and there's a lot of lack of joined-up thinking there. But we're also pleased to see a workforce plan. It's the first time, exactly as James has said. It's encouraging that it will be for at least 5 of the 15 years that it's meant to be there for. But there's nothing really on how it's going to happen. There's very little mention of retention, certainly retention in primary care, which, as I was saying, is a real problem for us. We're pouring water into the sink, but the plug is out. Training capacity, if we're going to increase the number of GP trainees, and again, we were delighted that general practice, I think, is the only specialty that is mentioned specifically in the long-term workforce plan. But again, if we increase the number of GP trainees by 50%, who is going to train them? As all our experienced GPs are leaving. And those that are there haven't got the capacity to take on additional trainees. How is this all modelled? Even the National Audit Office doesn't seem to know when they came to ask us on our contribution to the long-term workforce plan, and we asked them if they knew how it was modelled, because we didn't. We'd like to help. Proposals are very high level at the moment. We've had some of our key asks have been answered, such as expanding general practice training. Again, we're delighted that now the full 3 years of general practice training will take place in general practice rather than on hospital placements where we're filling rota gaps for other specialties. I think that enabling foundation doctors to spend at least 4 months of their foundation training in general practice is also a good thing, but they've got to spend it in practices that are thriving, not practices that are failing. And I think that's also going to be very important to make sure we get that right. Just another recent RCGP survey we did said that 84% of GP staff said there isn't enough space in their practices to take on not only these additional trainees, but also the additional roles that are coming through with other plans. And almost half of them said that there was a shortage of trainers, that couldn't take on more trainees. So that all needs to be joined up, otherwise it won't work. And we're getting used to what I call pie crust promises. Do you remember Mary Poppins? Pie crust promises, easily made, easily broken. So retention's really important for us. I think that ambitions for retention in the plan are not great. They're talking about retaining about 700 by 36, 37. That's not enough if 4 out of 10 GPs tell us that they're going to quit in the next 5 years. So these new GPs will be coming into what I would call a wasteland, and that's not going to be good for them, and it's not going to be good for our patients otherwise. So we want to help. We've got lots of ideas, and we'd very much like the government to listen to us. And in a funny way, they do listen, because certain things come back, months after we've mentioned them, but we'd really like to actually work with them, actually get our hands dirty, because I think that would help everybody, particularly the patients. And I think I'll stop at that point.
Many thanks, Camilla. So, Jacob, over to you next in the press.
Thanks, Sean. And just to confuse the camera, I'm going to stay seated. So, hi everyone, I'm Jacob, I'm from National Voices, and we are a coalition of 200 health and social care charities representing a range of different conditions and communities. So I'm going to try and bring a bit of patient perspective into this conversation. And having said that, I don't think I need to cover off the views of the workforce, because esteemed colleagues like Camilla, lots of professional organisations out there are constantly speaking on behalf of the workforce. So the thing I'd like to say from a patient perspective is that actually patients themselves and the public are talking a lot more about workforce pressures than they ever have before. And that's partly, I think, driven by what they read in the media. So a lot of all of us talking about this all the time. That message is permeating through that workforce is a real challenge for the NHS. But it's also coming through directly in how patients are talking about their experiences of care. And I'll give some examples of this. So over the 10 years I've been working in patient and public involvement, I've seen the general theme of feedback move from doctors and nurses are angels, then maybe in the 2015-16 era, it was doctors and nurses are angels, but they're really busy. They run off their feet. And now we see that we're not mentioning that doctors and nurses are angels anymore. We're just saying clearly there aren't enough doctors and nurses, and they're trying their hardest, but they just can't cope. And this is the sentiment that's coming through in millions of bits of feedback we see every year from the public, and they're worried about the burnout that staff are experiencing. So in that context, the workforce plan is very welcome. It's the first time that we've had a public shared acknowledgement of the scale of the challenge from both the NHS and government. I think that should be acknowledged. And things in the plan about training and recruitment are really, really important, because they are the things that are going to help us in the 2030s and the 2040s. And if you really want to keep yourself awake at night, look at the demographic pressures coming towards the system in the 2040s. That is genuinely scary and makes today's challenges look really small by comparison. So I think the recruitment and training is really important, but it's not an immediate fix to the challenges that we're experiencing. Retention, which is a big theme of the plan, is much more important in the immediate. And I think it's good to see things like changes to pensions and continual professional development and culture change that will help with retention. But I would like to see plans to go much further, in particular around the estates and facilities that we're expecting staff to work in. We've got buildings that are crumbling. We haven't got enough room for them. We haven't got enough teaspoons in staff canteens. This stuff is really demoralising for the workforce working in substandard situations. I also, on that retention point, we need to focus on what the staff should be working on. Clinicians have been highly trained. They spent years training to be able to do what they do. And we know that we make them do lots of things that don't require that training, lots of administrative functions. I think Jeremy Hunt said in the Times on Friday that doctors and nurses are spending a third of their time on admin functions. And I agree with him that that's outrageous. We shouldn't be spending that valuable clinical time on that. So we need to think about how we invest in the admin and the managerial capacity in the NHS to make sure we deploy resource appropriately. It's been mentioned that we can use AI and technology and data to do that, and we can, but I don't think we can do that right now. That is a medium-term reality. That in the here and now, what we need more trained administrators, more trained people to deploy the clinical resource effectively. I also think that there's a point to be made about kind of that right professionals in the right place. So we've talked about not necessarily needing more staff, but needing them in the right places. Social care is the other missing piece for me from the workforce plan. So we talk about integration, health and social care as being the way that we can make care more efficient, we can make it more personalised for people, we can make sure they get the care they need in the round. And yet we have an NHS workforce plan that sits in isolation of social care. And we know that we've got people in the community who are not well supported at the moment, who are at risk of being admitted to hospital. We've got people stuck in hospital who can't get out because we don't have the right social care support. So for me, I will finish on those 3 points that, if we want the long-term workforce plan to be a success, we need to focus much more on retention. We need to think about getting the staff to focus on what they're good at and get some more admin support in to relieve clinical time to focus on the patient. And we need something that's going to focus on social care and make sure that all the burden doesn't just fall on the NHS.
Lovely, many thanks, Jacob. And lastly, I'm really delighted to welcome Professor Juliet Wright. So the University of Surrey have been training medical professionals, nurses, paramedics for over 40 years, and you have a new medical school opening next year, I believe. And so really delighted to have you here and really just to hear what you have to say, because the type of institution that you'll be running is going to be key to actually delivering the plan that the government set out.
So thank you, Sean, and thank you for joining us. It's really nice to be part of this panel. And you're absolutely right. I'm like to make my comments about education, I suppose, right at that beginning of the journey. And Surrey has been training healthcare professionals for over 40 years, the nurses, but a whole range, midwives, paramedics, physician associates, and that's why I think representing new medical schools as one of the solutions to training more doctors, somewhere like Surrey, is a great opportunity, because I think it allows a really authentic experience for our students to train alongside all those that they're going to work with. And I don't know about Camilla, but it was very different to how we trained back in the day in our silo. So we'll be taking our students this time next year, which is very exciting, and it's a 4-year graduate programme. But we are limited at the moment to taking only international students, and we do have a few scholarship places, but we really look forward to the opportunity to being able to join and support the long-term plans. And it is sobering when you think about the numbers that are needed, for the workforce. And as has been said, it is about reforming and thinking of new ways, as well as retention. So there's just 3 little areas that I was going to talk about, which was how can new schools like ours, like Brunel, innovate. We need to use digital technology. We need to think differently and not just go down the same pathways that we've done. I think the retention thing is just so important. Our students, any of you who've got friends, family who've trained to do medicine, it's so difficult to get in, and such a shame that these brilliant young people, are not wanting to stay and, aren't motivated to stay, and that's a great loss. And then lastly, culture, which I just come on to at the end. But, as I said, it isn't one size fits all. Some of the older schools where I was in Brighton are, and that's actually, relatively new, but some of the bigger schools are full to the brim. So I think we do need to think about new schools that have new places, and where there isn't such a pressure on placement. And, I really like that thought of, can we do this faster? Can we do it in 4 years with a sort of very clinically relevant biomedical sciences at the beginning, clinically relevant anatomy, surgery, radiology, and then, opportunities for our students. I mean, I'm a geriatrician, to go out and work with the teams hospital at home and actually see, what the complexity of delivering for a, multi-morbidity, how complicated that is, and doing that with the team members, seeing how technology can support that. And there is an opportunity to think about different ways, part-time training, lots of colleagues who have worked in other healthcare professions who want to come and do medicine, with all that skill. That's a way that apprenticeship programs perhaps can support. They have so much knowledge, and they know what medicine is all about. And widening the talent pool, I think, is really important. So that retention issue, I saw, you've probably seen the data that says about a third of medical students don't want to stay after they've done foundation training. So I think it's really important that these new courses, our new schools, have structures that really guide and support strong professional development, so that these students can, they can progress, they can realise their ambitions, that they stay committed. And having some of the unintended consequences, I suppose, of improving doctors' working hours, losing that team, losing that mentorship. So I'm really looking forward to being able to mentor our students from year one right the way through and into their working lives, and to ensure that we foster research aspirations, leadership aspirations, so that these doctors have portfolio careers and stay with us, stay working in the NHS. And then just lastly, culture. It's actually one of my colleagues, Carrie Newlands, who led the research and the really sort of shocking paper about sexual abuse in surgical trainees, and is in fact leading the work to think, how can we tackle that? So again, that professionalism theme, those strong role models in a modern curriculum, I think is where education can really bring its part to, to supporting, the needs of the country. So, thank you very much for the opportunity to join the panel. It'd be really nice to, further discussions.
Pleasure. No, many thanks. And actually, all of you, I think, have really, really well articulated those three key planks that were in the long-term workforce plan. So actually, how do we grow the numbers? What are the key strategies going to be to retain? And then that third point around transformation. And that was something I wondered if I could pick up with you, James, which is I think you very well sort of articulated the sort of some of the larger sort of challenges in terms of where the healthcare system needs to go, changing burden of disease, actually the challenge of how we actually put equipment that works, and indeed new sort of technology in front of people, the digital transformation piece. I just wondered fundamentally, what are some of the things that you think are going to be most important, so actually that we do that transformation piece? What are the things that need to change, either in terms of the approach to medical education, or maybe some of the way that some of the services that we know are going to be key to support those new
it's an interesting one, because I was just reflecting on what people were saying, and one of the things in the long-term workforce plan, where it talks about the number and proportion of staff within mental health, primary and community care will grow by 73% by 2036-37. Now, that's tremendous as an ambition, and that's the sort of thing that I'm talking about. The recognition that we do need to have a better approach in terms of funding and staffing and at that primary care level. I mean, I've got a particular interest in mental health. I chaired the all-party group for mental health in my first term, and I'm thinking about the investment in the mental health workforce, which has its own particular challenges. So that shift towards a proper funding and staffing at that primary care level, I think, is going to be absolutely critical to the future. Now, I don't think it's all about. I accept that we have an issue with GP retention, but I think the future of primary care is not all about GPs. It's also about getting other, because the long-term workforce plan talks a lot about multidisciplinary working, and that applies at the primary care level as well. And I think that's a very, very important part of this transformation. So that movement towards prevention, that focus on primary care has to be right, but it's one of those where people talk about it as if it's a no-brainer, that it should be very easy, but actually it's quite difficult because it shifts the emphasis of the system quite considerably. And if we achieve that by 2036-37, I'll be a happy old man in that sense. But that's where I think the focus needs to be. And so we need to be really real about what that 73% increase in mental health, primary and community care actually looks like and how we can move towards it.
No, thank you. And Camilla, I was really struck by the statistics that you drew upon from the Royal College around the number of colleagues who felt like actually in terms of being able to support the skills mix that's already sort of on stream in terms of premises, things like that. Just actually in terms of achieving this plan, and obviously there are very particular commitments to, as you say, increase the number of GP training places by 50%. How are we going to do it? And indeed, how do we sort of think about ways in which we're going to be able to achieve the type of skills mix that James is talking about that we want to see in a sort of changing primary care?
So we have to think about where we want to end up. And we want to end up with a scheme for prevention that either delays or prevents the onset of quite a number of chronic illnesses that basically have their basis in lifestyle issues and socioeconomic issues as well. So prevention has to come from there. We have increased life expectancy, but what we really need to increase is healthy life expectancy. And if you actually look at the data, for people in the poorest decile, they have a much lower healthy life expectancy than people in the highest socioeconomic decile. So there's an awful lot of work to be done there. By moving public health into local authorities and taking it out of the NHS, we've lost a really important link, which I think we need to rebuild. We need to be working between primary care. And I take James's point that primary care doesn't equal GPs, but there's no doubt that GPs are very pivotal to the whole process of leading change. And there are many GPs I come across, in addition to all the ones who are seeing 70 patients a day, who are doing some fantastic work in their practices, some fantastic work in their ICBs, looking at data. So this is where data comes in as well, the intelligent use of big data to actually identify vulnerable populations, vulnerable groups, vulnerable families, and target those people. And that's already happening. It isn't something that we'd be looking for in the future. But we need to be doing it on a vast scale, right across the UK, not just in good patches, So I think there's an awful lot there to be done. And by losing GPs at the rate at which they're going, we're losing a really valuable resource that we've paid a lot of money to get. And it just seems to be such a waste. So for me, it's really important that we focus on retention. And it isn't just about occupational health and well-being. It's also about, for example, when GP trainees finish their training, quite a lot of them are frightened to go into practice because they're afraid to be left the last man standing. They're afraid of financial implications. They're afraid of the responsibilities of being a partner. And so they hang about and they do locums. Or they may stay as a salaried GP in the practice where they trained, which is what my daughter's done. It's safer. It's safer there. And they keep offering her a partnership and she keeps saying, I'm not ready yet. I'm a bit worried about this. I'm not sure. So I think that what we need to be doing is adding in something that's already existing but isn't working well enough, which is a new to partnership fellowship scheme. A 2-year fellowship scheme that allows newly qualified GPs to get stuck into a practice, get their feet under the table, really understand what general practice is about, really see the joy of practice and continuity of care and getting to know your communities. And with that, most of those people will then stay. Instead of, at the moment, feeling that the world is their oyster and they can go to Canada or New Zealand or wherever, which I think is a terrible waste.
Absolutely, and great that there's something practical we can pick up and sort of stress test as a policy as well. One of the things I was really struck by, Jacob, in your opening remarks, is that commentary around the non-clinical workforce, and in terms of actually maximising, let's say, the use of the big data, the population level data, really understanding where the need is in terms of actually where we need trainees in the system, the specialities required, and then actually delivering those digital transformation programs as well. So whether that's using the NHS app better, etc. These are things fundamentally that are probably going to be led by non-clinical staff. I just wondered, what do we need to be thinking about in terms of that? Because obviously, as you say, it was a mission, or many people reflected it was an omission from the long-term workforce plan.
Yeah, absolutely, Sean. I think it was an omission from the plan. And I think that if we think about how busy clinicians are at the moment, and we talk about implementing new uses of technology and data and artificial intelligence, they simply don't have the bandwidth to implement it, let alone necessarily the the specialism in it. So just because someone is an excellent doctor or nurse does not mean they will be an excellent person at analysing data or using these new tools. We need to understand that it's a different it's a different profession, it's a different skill, and actually it needs to work in harmony with the clinicians. So we need to think about how we're recruiting the right people with those skills in, and you can't just do it at national level. So you can't just have one central big data analytical team going, we need 100 GPs in that town over there. That's not going to work, because you actually need the local knowledge and the local understanding and the work and the link in with communities to understand what data it might be missing from some of the assumptions I'm making in my data analytical model. Have I planned every single health and care system on the same model? Because what works in a rural area versus an urban area is massively different. So you need that local capacity on data and analytics. And that's just on the sort of the transformation side. On a day-to-day side, actually, admin staff to help better manage waiting lists. Actually making sure that we're doing good communication to patients, telling them they haven't been lost in this sort of mass of people waiting for care. That is something that we overlook massively at the moment, but it's a huge part of what patients say they find most frustrating, is that they often don't know where they are, so they end up contacting the GP or trying to contact the consultant at the hospital asking, where am I on the list? And again, that's not a good use of the GP or the consultant's time. That's a admin and a sort of how I manage someone through their journey point. And again,
Can I
that's
make
just
a suggestion there? Do you not think an Amazon-style system would be fantastic? So as soon as you refer a patient, goes into some database, the patient gets a notification, you've been referred. As soon as it's been read by the consultant, the patient gets, so you can follow the trail and you know where you are. And you get some idea as to how long you're going to have to wait. It could all be done electronically. It doesn't have to be done by people, which at the moment it is. Yeah. So what happens to me is a patient comes to me and says, I haven't heard for 3 months, my hip's really hurting, I have to crawl up the stairs to get to the toilet. What are you going to do about it? And then, we go ringing round trying to work out how long it's going to be and can we expedite, and then you have to ring the patient and tell them, and, it's horrible. Wouldn't it be much better if we actually had a system? I mean, if Amazon can do it, why can't we?
Well, precisely.
That's a very. If Amazon can do it, why can't we? I think speaks to a very fundamental question, because one of the things I was alluding to in my remarks was a question about the operational capacity of the NHS to actually innovate at that level, and whether or not it would be possible for that. Because there's been so many attempts to do it. I don't want to be a pessimist, but I'm just questioning, from what I've seen within the NHS, because of the variable nature of innovation at that level, whether or not that is an obstacle for us achieving what we all want to achieve, and to think through how do we get through those obstacles. That was.
Yeah, no, it's a fundamental point, and actually we very much support that position around an Amazon-style tracker. So actually there is that transparency around the patient journey, sort of that seamless sense of where you are and who's responsible for your care. And it's going to become increasingly important with people with multiple
a long
conditions.
time ago, because I was before Juliet in Surrey, which is very much an engineering university, and it has an engineering for health research strand, a really strong one. And the engineering researchers said to me, we can make you anything you want, but you have to tell us what you want. And so one of the things we were trying to do was to create new doctors who had a better understanding of what they wanted. So that's something, because we're not the ones that should go off and be writing software all night. Somebody else who's much better at it should be doing it.
Absolutely. And Juliet, one of the things I wanted to ask you was about, there's this exciting opportunity at SO where, as you say, you have this heritage of training medical professions for many decades, and obviously the new medical school will have obviously bringing doctors on stream as well. I wondered, what are the key things that you're going to be doing differently in terms of the approach to medical education, and how does it sort of fit into some of the challenges and questions that we've been raising?
Well, I think one of the things that I'm most excited about is working together from the word go. So having our students taking part in Balient groups with nursing students right from year one, so appreciating the skills and challenges of other healthcare professionals. And then, again, different to my experience in other medical schools and my own, lots of safe simulation with other students, so that you begin to really appreciate what those really key and valuable members of the team bring to the journey. And I think that will then change culture, so we're talking about all that research of people not respecting other people's roles or understanding roles. And from my own journey of, starting out as, as a houseman back in the day and being so terrified that it was all on me when it actually wasn't all on me. I just didn't know what the other healthcare professionals were doing. I think it creates more of a team and more of a shared responsibility, I think. So that is a change in ethos to the way that medical students have traditionally been trained. I do think that the way to survive a 35-year career in what is a demanding job is to play to the strengths. They are often, come from a wide variety of sort of academic backgrounds, is make sure that we don't lose that. So, again, doctors, if you look at in Europe, doctors are all involved in research projects, be that small, be that just encouraging a student, a PhD student. And I don't think there's time for clinicians currently, to promote, that extension. And so therefore supporting portfolio careers. So that's things that would be in our programme, and just keeping stuff very clinically relevant. So there are main goals. But I have been really surprised as to how many nurses and physios and paramedics who have worked for a number of years and with all that knowledge then see themselves developing into into another type of medical profession, into a doctor, and that's where the sort of 4-year course or the opportunity to do that as an apprenticeship gives a new angle. So,
super. No, thanks for that. I'm keen to give you all an opportunity to put your questions to the panel. So if you have any questions, please do raise your hand. If we start with this gentleman in the third row here. Do we have the mic?
Excuse me.
Excellent. Just this gentleman over here. Please, if you could just say your name and organisation.
Thank you. Rob Burley from the charity Muscular Dystrophy UK. Just a quick comment and a question. My comment is just to welcome Jacob's point about the non-clinical workforce with the condition like a muscle wasting or weakly condition. You're having to navigate multiple professionals, multiple engagement. And it's one thing knowing where you are in that system and knowing where you are in it, but actually getting some advice that might be non-clinical about where could you go next or how to coordinate it, I think is really crucial. So it's great to hear that point. My question is just on the panel's thoughts on the charity sector's role in supporting the NHS workforce, perhaps informally. I think that's happening more and more. So we provide upskilling events and e-learning tools, including hosted by the Royal College of GPs, so that people can understand the conditions and the needs of the patients. And increasing services are coming to us to ask us to fund their events, to upskill their workforce. And I'm just really interested in that sort of dynamic changing. We do it because we see the benefit it brings to the people we're here to support, but ultimately there's an argument that should be being done by the NHS itself as part of the training budget.
Yeah, really, really great question. So maybe if we just pick up that one first, and then I'll come back to the question. So how do we maximise the materials expertise from the third sector to
training? My view would be that we maximise the third sector as much as we can. I mean, I don't think it's necessarily just the responsibility of the NHS if there are areas of expertise within the third sector that can help. I think it would be a very good thing because it brings more energy, new ideas, a different perspective. So, I mean, I would be broadly supportive of that.
Yeah, of course. And as you say, you work with us already, as do many other organisations as well. And we welcome that. We really do, because, you bring an additional strength that we don't have for patients and for our members. I think that certainly GPs over the last 10 years or so have increased the amount they do with third sector and with other voluntary and community organisations, particularly through social prescribing. Whether it's a local community garden project or whether it's working with community police or with schools, there's a great deal more happening, and there's a big push as well, which is coming through the GP training as well, so that all newly qualified GPs are also very interested in this aspect of providing materials for patients. And certainly all of the sort of, hot topics, CPD days that I go on have got links to third sector organisations or patient information leaflets, that sort of thing. And so, yeah, we're very busy. It's a bit like having more tools in your toolbox.
Super. And Jacob,
just a quick point. I agree. I think I've seen more and more statutory services and professional bodies working with the voluntary sector, and that's great. In 2 areas, in delivery, that makes a lot of sense because the voluntary sector can deliver sorts of services and community support that the NHS can't. And on that training point that you were mentioning, it actually brings the service closer to the patient, because we can, through the voluntary sector, we can bring people with lived experience into the room. We can co-produce the ideas together, and they're more likely to work first time because then we've done it in partnership. So I think that's critical. But the main bit is about funding that. It doesn't come for free, and still too often I see requests to us, can you get a patient to this event next week, to, with no respect of their time, no respect of them having to retell their story, the trauma that they may go through and the support they may need to do that. So actually, being at the NHS investing in the VCSE is really important.
Really useful. And Juliet, did you want to add any reflections on Thursday? Have you got that in your plans in terms of how you'll engage with local organisations?
Yeah, absolutely. We did do that quite successfully in my previous institution in terms of widening the placement for students that they would have experience in the third sector. But again, it's all about that clinically relevant journey, isn't it? Having the patient voice when you're learning about X condition, that the patient is in the room in whatever form. But I do agree, it shouldn't be. It needs to be costed in, appropriately. But it's vital. It's vital right from the word go. It's that the patient is there.
Brilliant, thank you very much. So we take another question now. So do raise your hand. Can I just go to this lady over here? You just say your name and organisation, please.
Hi, excuse me. It's Carol Bernstein, and I'm from the Bury North and South Association. So I wanted to understand from you, do you have an idea of what is causing all of these various staff to be leaving your organisations, and what you could do to stop it?
Very good question. Could I put that to you first?
Yeah, okay. I think it's very simple. It's workload, with too little workforce. So the demand far outstrips the capacity. And when you're exhausted every day, you look for ways out. You try to cut down the number of sessions you do. If you can leave early and retire early, you do. If you can go to other places where the pay is more and the work-life balance is better, you go. Really sad, actually. I was visiting 3 PCNs in Essex a few months ago, and there was a GP couple there who were just about to emigrate to New Zealand in their mid-40s, I would say, because the workload was just too dreadful. And one just felt really sorry, really sad that was happening.
Is that because of demographic, or is it how much COVID had to do with that?
It's fascinating.
Dreadful increase.
Yeah. It happened, yes, because, I agree with you. We were coping. We were busy, but we were coping pre-COVID. Then there was a silence for a few weeks, months at the beginning, the first lockdown, and we were all thinking, well, where is everybody? And then there was a sort of tsunami, but it wasn't just people who'd been hanging on for COVID. We're just seeing a large number of people who need help. Now, some of them could be helped by other healthcare professionals. They don't have to see the GP. And again, there are things now being put into place to enable that to happen with care navigators. But nonetheless, there is still, our workload has gone up by between 10 to 13%, depending on where you are in the country. And it's not just in Bury and it's not just in Essex. It's everywhere, absolutely everywhere. And what we're seeing is people who are ill. They're not making a fuss about nothing,
Yeah. And I wonder if I could just ask you, James, what are the things that you would like to see to really address this?
Well, I think it's an interesting point about without being technical about it. The demand profile, the profile of the post-pandemic demand on primary care has changed, and I think we really need to understand that. Why, in terms of the composition of that demand and how it can be managed perhaps in a different way, as was remarked, finding different pathways for people. That there is a kind of, we're going through a bit of a cultural transformation, possibly among older people, that they have traditionally wanted to see a GP face to face, and that model perhaps is not the model of the future, and also finding other pathways through when they're presenting with things that can be dealt with other people. So the profile of that demand has changed, and I think we're lagging behind, and that's why we're having this discussion about a long-term workforce plan. We're lagging behind about how we actually respond to that changed profile of demand. Because it's almost like post-pandemic, we've had this rising level of expectation as well as increased demand about what can be delivered by whom and where. So I think we're still in, as I think it was Chairman Mao said about learning the lessons of the French Revolution, it's too early to tell. It's probably too early to tell about the direct effect on the demand profile of the pandemic, but it's certainly there, and we need to understand it better so that we can respond with the appropriate capacity, which is part of the discussion that we're having.
And Jacob, did you want to
just very quickly, I think it's also a case, I agree completely with Camilla, that demand is outstripping supply of capacity in the system, but we're also not managing demand particularly well. So we talked a little bit about earlier about referrals, about people going to their GP, chasing up where they are in the system. I did some research in my last organisation this time last year that showed that as many as a fifth of referrals are bouncing back. So for some reason they're getting lost in the system and the person is going back to their GP for another appointment. So they're still sick. They haven't been seen. They don't know what's happened to their referral, but that's another appointment we've added into the system because we're not managing demand particularly well. Similarly, I think also things like the cost of living crisis are really putting a massive pressure on people managing their conditions. So last winter we saw 1 in 10 people decided not to take up an NHS prescribed drug because they were struggling to afford other things like heating and food. Now, that's precisely at the time that we need people to be most managing their conditions so they don't add additional pressure onto the system, because for a very small prescription charge. So we're not really thinking about other things that are making it not possible to manage demand particularly well in the system at the moment.
Mm. And I wondered, Juliet, how you're locally going to challenge that sort of chicken and egg dynamic that we've been talking about here, where we've got the clinical service under real pressure, and then the expectation and sort of the these new professionals we wanted to sort of bring on stream at pace. I just wondered how you were going to try to solve that tricky balance.
Well, it is tricky, and in my clinical work as a general physician, as an elderly care doctor, I have seen real promise actually in services such as hospital at home. So, where I work at the Royal Surrey, a really innovative team of clinicians have gone forward, and now with a team of advanced nurse practitioners and physician associates are managing sometimes 10, 15 patients. It seems small, but just starting, and testing the waters. And patients that I would normally admit, I can refer and on board to hospital at home, patients can be seen before they come. So I do see that as a way of, a very effective way of managing an ageing population with multiple comorbidities and bringing in the team where actually checking the blood results and it's all going the way we expect. Quick phone call to the consultant manages that situation where normally that would be the whole of admission. So, and actually our students being part of that. So from an education perspective, seeing that working, but it is nice to see innovations like that starting to pop up.
Yes, we have that system where I'm a GP as well, and it is brilliant. But it doesn't work in the evenings and it doesn't work at weekends.
Yeah.
But what I do see is a system, the hospital at home system for us, provides additional services for patients as well. So whereas before maybe somebody might have somehow managed without an OT, an occupational therapist, to come and see where they needed handles and, aids to help them around the house, and they'd have just managed or bought their own. Now through Hospital at Home it can be done systematically so that everybody who's referred to them will get that kind of consideration, which I think, so it's actually also widening what's available. So actually the service is improving. It's not just that it is struggling to keep up, but it's also improving at the same time.
But I could say that it could be scaled up to work at evenings and weekends. There's no reason why not, should it? In the way that we, I suppose that's the next step, isn't it?
Yeah.
We've got time for one final question. So perhaps if we go to that gentleman just at the back in the corner over there, and if I just ask panellists when I sort of bring you in, if you could also have a go at sort of answering the top line questions, sort of as sort of closing remarks. So name and organisation, please.
My name's David Goodhart, and I work occasionally at Policy Exchange. Does the NHS workforce plan factor in the feminisation of the increasing feminisation of the professional workforce in the health system, given that a lot of young women still want to have babies and families, and therefore want to work part-time? I mean, I think we saw this with GPs, that a lot of women GPs want to work part-time, so that the big increase in GPs didn't go as far as people expected it to. And secondly, sort of related, and this is perhaps more of a sort of cultural question that isn't really subject to policy or politics. If you look at the kind of lower levels in the care system, sort of nursing downwards, as it were, nursing, social care, are we actually just going to see a falling off of the number of people who want to do these very emotionally stressful face-to-face care jobs in the future? Post-Christian, sort of post-female altruism world, there used to be a sort of captive sort of audience of young women who'd been socialised into care from an early age, and they're not really there any longer, and they actually just aren't going to be the people who want to do care jobs.
Interesting provocations. Would you like to reflect on those?
Okay, I had a feeling it might come to me first. Feminisation of the medical workforce. Do you know, when I was a much younger GP and had all my postgraduate qualifications after my name, I used to joke with a grain of truth in it that I needed a certificate of sterility as well as all the other diplomas and memberships and what have you. You've got to allow people to be people. You've got to allow them to be humans, to have families, and I think I'm a better doctor for having the two that I've got. I think that I don't know is the first answer to whether or not the modelling included this or not. We did ask, actually, when we had meetings with NHS England. We did also point out that there needed to be time factored in for the amount of supervision that GPs are going to have to do with all the additional roles that are coming into practices. Would that be factored in as well? We got no reply. And as I said in my preamble at the beginning, when the National Audit Office came to talk to us, we asked them if they knew how the modelling was done, and they said no, they didn't either, and they were trying to find out. So I don't know if James has got the answer, but I don't, I'm afraid, as to whether it was factored in or not. But there's no doubt it's not just about feminisation of the workforce. Everybody coming through medical school now is thinking about work-life balance. Not everybody, as we used to be. We got on that treadmill and we didn't get off it. And we worked 1 in 3s and 1 in 2s and 100-hour weeks. People are not willing to do that anymore, and we need to be aware of that.
Thank you. So, James,
I don't have the answer on the modelling, I'm afraid, but it's a very interesting point. I think my reflection on the first part of your question, which is that in terms of the culture and retention, we do need to be reflecting different, as you say, work-life balance, different perspectives. We're living with a modern workforce, and that's part of the cultural challenge which I was describing at the beginning about how we're actually going to deliver on this. So I think that's absolutely critical. Thinking about the impact of that. Traditional working practices within the NHS, working 100-hour weeks and all of that, which was part of the culture, we need to move beyond that. and we need to think about how we move beyond that. And I think you make an interesting point about the social care workforce as well. I mean, I've always thought that what we need to be doing is raising the status of the social care workforce. And there might be a number of policies to think about in the future about how we do that, because the issue we have is that it's not seen as a profession that has status. It's become increasingly commodified, and I don't think that's a good thing. And then there is probably a subsidiary thing about social care in the future with the application of technology. Again, I'm not a technology evangelist, but I do think that technology can help with the delivery of social care. I'm not just talking about robots delivering social care, but I think it is a moot point about what that composition of that future social work. So a raised status of the profession, which isn't a commodified profession, fused with our ability to use technology to help elderly people have more, have productive lives as they get older. I think that's critical.
Many thanks. Jacob, closing remarks for you, and then final remarks from you, Juliet.
Okay, so I don't know how the modelling for the long-term workforce plan was done either, but I did ask a direct question about whether they considered the increasing trend towards more part-time work in the NHS, and they had factored that in to some extent. So that's not just related to women, that's the whole, as Camilla was saying, the whole trend to the workforce has changed, what people are willing to do. So they have factored that in, I'm assured. On the second point about social care, I actually don't think I think it's the one profession I can see that where AI and robots and tech will not make a huge difference. It is so fundamental, the human nature of it in its caring role, and actually the physicality of being a social care worker means that job's not going to get automated. Policy wonks, our days are numbered as we get replaced by AI machines. But I think social care and market forces will drive, the value we place on that. As more of us get older, and the more, we will have to pay them more. We'll have to respect them more. I agree with James entirely. Raise the status of the profession. It badly needs it.
Well, yeah, I mean, I echo much of what's been said. I think that in answering, in solving the workforce issues, new schools with new innovative programs will do exactly as Camilla is saying. I don't think it's so much about women. I think it's about a different way of working. I think work-life balance, portfolio, encouraging clinicians to do good clinical work and teach, or clinicians to do good clinical work, research, or do other stuff, and keep healthy. I think that's the key. And so I definitely think that, new innovative programs, it's like ours, but other schools as well should deliver that for the new students coming through. And absolutely, from a social care perspective, it's about value, isn't it? Valuing your job, valuing your role. And I think if those professions feel part of that multidisciplinary team, I think that's really key. So I completely agree with James. So I think there's great opportunity to achieve all of that.
Many thanks. And yeah, an optimistic tone to finish on, I think is very, very welcome. And I think it's been quite striking in the conversation how what's been set out in the plan feels very much necessary, but given the remarks you made at the beginning, James, and reflections of the rest of the panellists, perhaps not going to be sufficient. Thinking about digital transformation, the different ways in which we're going to need to work to ensure we meet the needs of our population in the future. So just to say a really, really big thank you to the University of Surrey for their support of today's conversation, and I hope that you'll all join me in thanking our expert panellists.